Welcome back, everyone, to today's Masterclass Explainer. I'm going to be stepping into the shoes of your maxillofacial professor today, and we're diving straight into a super high-yield, comprehensive exam prep on trauma. Look, if you've got boards or practicals coming up, this is exactly what you need. We're going to cover the whole shebang, literally, from the trauma bay straight through to the operating room, using exactly what's in the literature. So grab your notebooks, let's get into it. Okay, check out this quote. The aim of the treatment of any fractures is to keep the patient alive by life-saving measures. Look, before you ever even look at a broken bone, before the jaw even crosses your mind, you absolutely must secure the patient's life. Maxillofacial trauma is intense, right? Your very first job is keeping that patient breathing and stable. If you miss this basic fact on an exam, you're going to fail the station right there. Okay, let's dive into this. Here is our clinical pathway syllabus for today. First up, initial trauma life support. Then, mandibular fracture fundamentals. Third, clinical and radiographic diagnosis. Fourth, treatment through reduction and fixation. 5, managing condylar fractures. And finally, number 6, post-op care and complications. All right, section 1, initial trauma life support. Now, board exams always start with emergency stabilization. You've got to know your primary survey cold. I'm talking about the classic ABCDE acronym, and guys, this is absolutely non-negotiable for the trauma bay and your exams. Step 1 is airway management and C-spine control. Step 2 is breathing and adequate ventilation. Step 3 is circulation and shock management. And remember, hemorrhage from the maxillofacial region can be massive, especially if it involves the carotid, facial, or lingual arteries. Step 4 covers drugs for pain and infection. And Step 5 is exposure of the patient. Let's actually zoom in on the A of this primary survey. Because airway obstructions are super high-yield test material. Why exactly might an airway be blocked in facial trauma? Well, it could be the tongue falling back in an unconscious patient, or maybe a maxillary fracture that drops the soft palate right onto the tongue. But underline this next one in your notes. Bilateral parasymphyseal fractures. This creates what we call a flail mandible, which causes the tongue to displace posteriorly. To fix it, obviously, you need a patent airway. The jaw thrust, placing your hands behind the angle of the mandible and pushing downward and forward, is noted in the literature as the absolute safest manual method. If manual clearance fails, then you're moving to a surgical airway, like a tracheostomy or a cricothyroidotomy. Moving on to section 2, mandibular fracture fundamentals. So once your patient is stabilized and out of immediate danger, we shift our focus to the actual pathology of the jaw. And this brilliantly illustrates the anatomical classification of mandibular fractures. You've got to be able to identify these sites in your sleep. Notice the symphysis right at the midline, flanks by the body. As we move posteriorly, we hit the angle, then up the ramus to the coronoid process interiorly, and of course, the condylar and subcondylar regions posteriorly. Pinpointing exactly where that bone failed is step 1 in your classification. Step 2 is looking at the nature of the fracture itself. Let's quickly review these physical states. A simple fracture is just a clean break. A green stick fracture, where one cortex is fractured and the other is just bent, is something you'll commonly see in pediatric patients. Now, a compound fracture is critical because the bone is exposed, very often into the oral cavity right through the periodontal ligament. And comminuted fractures, whether they're simple or compound, mean the bone is literally shattered into multiple pieces. You need to be able to visually distinguish these on a radiograph instantly. Okay, let's pause for a second. Here is a classic pimping question for rounds. What crucial factors dictate the degree of displacement in a mandibular fracture? I mean, why do some fractures stay perfectly aligned, while others just pull wildly apart? Think about it for a second. All right, if you said muscle pull, you hit the nail on the head. Take a look at the red arrows here showing the direction of muscle pull. The muscles of mastication are incredibly strong. It's the direction of the fracture lines, the direction of this muscle pull, and the presence or absence of teeth that actively displace those bony segments. A fracture line can be considered favorable if the muscles pull the segments together, or unfavorable if the muscles are pulling the segments apart. Make sense? Which brings us to section 3, clinical and radiographic diagnosis. A thorough history and a sharp clinical exam are absolutely your cornerstones here. You don't just rely on imaging, your hands and eyes tell the story first. Star this diagnostic protocol in your notes right now. Always take an ample medical history and understand the mechanism of injury. Extraorally, you're inspecting for facial asymmetry and palpating for step deformities. You're literally feeling for a ridge where that bone is broken. Intraorally, you want to look for a sublingual hematoma, broken teeth, and those crucial signs like malocclusion or premature contacts. And finally, perform bimanual manipulation of the fractured segments to test for mobility. It's only after your clinical exam that you confirm with imaging. Look at this panoramic radiograph. Notice how clinical suspicions of a fracture, maybe it was a step deformity you felt on the inferior border, or a malocclusion the patient complained about, are confirmed visually right here. You can clearly see that loss of continuity in the bone. It's like a giant puzzle, and the radiograph is just the final piece.
All right, Section 4, treatment, specifically reduction and fixation.
Now we're entering the surgical core of the explainer. We've stabilized the patient, we classified the fracture, and we've diagnosed it. So how do we actually mechanically repair the damage? The basic principles here are reduction, fixation, and immobilization. Reduction is just repositioning the fractured segments back to their normal anatomical pre-injury state. You've got to know when to use closed versus open reduction. That's a classic board exam distinction. Closed reduction is done bimanually for recent injuries that have minimal displacement, and it's heavily guided by the patient's occlusion. Open reduction, on the other hand, means surgically opening the area to access the bone. This can be done via transmucosal intraoral, transcutaneous extraoral, or transbuccal trocar approaches. So once it's reduced, we need to fixate it. With indirect fixation, as you can see here, the hardware, like these arch bars and elastics, is applied away from the fracture line itself. This is almost always accompanied by closed reduction. Basically, we're using the teeth in the occlusion to hold the jaws in the correct position while the bone heals underneath. Now, what's really interesting about this slide is the crucial shift to direct fixation. Here, we've used an open reduction to actually expose the bone, and the hardware, the plates and screws, is applied directly across the fracture line surgically. This directly stabilizes the segments right at the site of the break. Let's walk through this high-yield comparison table for direct fixation hardware. If you use wire osteosynthesis, well, it's non-rigid and it needs supplemental maxillomandibular fixation, or MMF, which means wiring the jaws shut. Many plates are semi-rigid, placed along Champy's lines of ideal osteosynthesis, and usually just need short-term MMF, so like 7 to 10 days. Rigid fixation, using dynamic compression plates or lag screws, provides functional, stable osteosynthesis and primary bone healing, meaning absolutely no need for MMF at all. Oh, and remember this little clinical pearl from the text? When you're placing screws, use monocortical screws at the superior border to avoid damaging the tooth roots and the inferior alveolar canal. But bicortical screws are applied at the inferior border for absolute strength. Next up, Section 5, managing condylar fractures. I'm warning you guys right now, the condyle is notoriously heavily tested on both your practicals and your written exams. The thing is, most condylar fractures are treated with a closed method, short-term MMF followed by aggressive physical therapy to rehabilitate the muscle. Because closed is the standard, the exceptions are absolutely critical to memorize. So here's another rapid-fire clinical scenario for you. When is open reduction and internal rigid fixation absolutely indicated for a condylar fracture? Well, here are the absolute indications straight from the literature. You must open if the condyle is fractured and displaced up into the middle cranial fossa. You must open if there's a foreign body in the joint capsule, or if you've got a lateral extracapsular dislocated condyle. So the crucial point is this: if there's a mechanical block stopping the jaw from opening, or an absolute inability to bring the teeth into proper occlusion using closed reduction, you literally have no choice. You must open and rigidly fixate that joint. And finally, Section 6, post-op care and complications. Okay, so you've placed the hardware, the fracture is reduced, but guess what? Your job is not done. Patient management after surgery dictates the final outcome. Immediate postoperative care is all about airway safety. Think about it. If a patient wakes up with their jaws wired shut in MMF and begins to vomit, they can easily aspirate and die. This is exactly why keeping wire cutters at the bedside is a mandatory life-saving protocol. And trust me, if you forget them, your chief resident is going to have your head. Long-term, you need to monitor for complications. These include things like plate exposure, infection, nerve injury, or the bone failing to heal properly, which leads to non-union or a crooked malunion. And that brings us to our final provocative thought for this masterclass explainer. Ankylosis, the pathological fusion of the TMJ, is one of the most devastating long-term complications of condylar fracture. I want you to really think about this. If a patient develops joint ankylosis down the line, where did our fracture management fail, and what could we have done differently? Was our immobilization period too long? Did we fail to initiate muscle rehabilitation early enough? Or did we maybe miss an absolute indication for open reduction? Connect these post-op complications back to your initial treatment choices. Keep asking yourselves these questions, and you are going to crush your exams for sure. Keep studying, and I'll catch you in the next explainer.